Bismillah ar-Rahman ar-Rahim. Hello, this is Dr. Iman Sheikh, and we are discussing our first ulcer and first topic related to oral ulcerative lesions or oral ulcers. By an introduction, we have to differentiate between erosion and ulcer. They are different lesions. Okay, clinically, you can distinguish them, but if you know the difference between erosion and ulcer, you can easily detect each one. So erosion is a shallow crater or depression, so it's only superficial damage of the epithelium. Okay, so here we are losing partial of the epithelium, while ulcer it's a deep crater or depression that extend through the entire thickness of the epithelium surface and involve the underlying connective tissue. So this is a deep destruction. So here we can complete loss of the epithelium. Here in the picture you can find the difference between the erosion and ulcer. So to understand it more, you have to memorize the layers of the epithelium. Okay, starting by stratum corneum or corneal cell layer, then stratum lucidum, stratum granulosum, then stratum spinosum or spinous cell layer, and the last one is the stratum basal or stratum basale or basal cell layer. So what's happening here? So if you want to detect it more, the ulcer complete destruction lead to connective tissue to be covered with granulation tissue. So your body as a defense mechanism not to be exposed area, the defense mechanism will be granulation tissue formation. Okay, so at the first sight, the ulcer will appear white or creamy, grayish because of the cover. You can see only red margins with some ulcers. That's regarding localization of the infection by multinucleated giant cells, so it's an inflammatory behavior. Okay, regarding the erosion it's a partial destruction showing the blood vessels. Here we have the thickness of this epithelium, okay, is decreased. So the behind or the beyond it structures such as blood vessels will be visible, giving us the red color of this erosion. Okay, so the thin epithelium still there is two layers by maximum. Okay, classification. Okay, oral ulcers can be classified according to the etiology, the causes, okay, duration, presence, the mode of onset, or the clinical presentation. Starting by the etiology, this could be classification and could be oral ulcers causes. Okay, the first etiology is traumatic, or it's known as the reactive ulcers. It could be occurred due to the mechanical irritation, chemical irritation, thermal burn, in addition to vesiculopullous and erosive lesions. Why this is mentioned here? Because pulla will be traumatized and then rupture into ulcer. Also, radiation burns and anesthetic necrosis. Also, anesthetic necrosis due to the hard or traumatic injection of the anesthesia solution to the oral mucosa. Okay, so the first cause is traumatic or reactive ulcers. Examples for mechanical irritation is, for example, sharp tooth. Okay, chemical irritant. Those patients who applied the tablets must be swallowing. No, they are applied it to the oral mucosa. They think it will alleviate the pain. Okay, the thermal burn, such as pizza burn. Chemical irritants also can be caused by dentists, especially during the endodontic treatment. Okay, Let's move to the second cause. It's microbial agent, either bacterial, viral, or fungal infections. Bacterial, the very common, which is necrotizing ulcerative gingivitis, or tuberculosis and syphilis. Okay, all of those causing ulcers to the oral mucosa. Viral, we have many virals. They are herpes, human herpes viruses, herpes simplex, herpes zoster, and herpingina, hand, foot, and mouth diseases, ulcers. Fungal, we have histoplasmosis. Neoplasm, of course, squamous cell carcinoma, and immunologic reactions related to autoimmune diseases or disturbance in the immunosuppressant substance in the body that can cause disease or ulcers in the oral cavity, recurrent aphthous ulcers or stomatitis, Behçet's syndrome, and autoimmune diseases, vesicular bullous diseases such as pemphigus vulgaris, mucous membrane pemphigoid, lupus erythematosus, and lichen planus, epidermolysis bullosa, and drug eruption diseases. Okay, blood disorders. Also, some blood disorders can manifest orally as oral ulcers, such as anemia, leukemia, and neutropenia. GID diseases, they are three diseases common: celiac disease, ulcerative colitis, and Crohn's disease. Drugs. Cytotoxic drugs. Some drugs, as a side effects of them, oral ulceration appears as an allergic reaction. Okay, these are some examples for ulcers associated with infections, including viral, bacterial, and fungal. Blood disorders causing oral ulcers also either red blood cells disorder, anemia, or white blood cells disorder, including leukemia and neutropenia as famous disorders. Okay, according to the duration, oral ulcers may be classified according to the duration into short-term ulcers and long-term, or we are name it persistent ulcers. So the short-term ulcers, those ulcers which disappear within 3 weeks, either spontaneously or are as a result of non-surgical treatments. Okay, examples of these short-term ulcers: traumatic ulcers, recurrent of the stomatitis ulcers, and vesicular bullous lesions. Okay, uremia and chancre, and ulcers secondary to non-infectious diseases such as uncontrolled diabetes, blood decreases, and immunocompromised patients, and also related to GIT diseases also. And persistent ulcers, those ulcers last longer than 3 weeks, may disappear after weeks or months, could be considered as a malignant ulcer until proven otherwise. Normal or most common ulcers would be of a short duration, okay, that is heal spontaneously or with non-surgical treatment, okay. When those ulcer doesn't heal or spontaneously regress and standing for more than 1 month or more, they are called persistent ulcers, and the patient will be precised as squamous cell carcinoma or cancer in general. So these ulcers must be biopsied to rule out the malignancy. Okay, some of the persistent ulcers characterized by remission and exacerbation. So some ulcers will stay for 2 months or 1 month, for example, but it will regress, okay, and appear again in another episode. So remission and exacerbation appear again. Examples for those ulcers long term related to chronic diseases, basically bullous diseases, which are pemphigus vulgaris, bullous pemphigoid, and mucous membrane pemphigoid. Also, lichen planus erosive form and lupus erythematosus. According to the presence, can be called primary ulcer or secondary ulcer. So, primary ulcer, that ulcer from the beginning, starting as ulcer, may be preceded by macule or tingling or changing in the color of the epithelium that regarding the destruction occurred, but it wasn't preceded by vesicle or pullar lesion. So, ulcers preceded by pulla or vesicle known as secondary ulcer. Why? Because vesicle started, the lesion started by vesicle, and then this vesicle rupture, then ulcer appear. So primary ulcers such as traumatic ulcer, infective ulcers, infective regarding only bacterial and fungal, because viral recognized as secondary ulcers. Neoplastic squamous cell carcinoma also starting as an ulcer, systemic, those ulcer regarding systemic disease such as GIT and bleeding disorders, ophthalmomatitis, Behçet syndrome, and Reiter syndrome. Oral mucosa is thin, so um, it will break rapidly into ulcers. Okay, the vesicles and pulla that appear in the oral cavity will break easily and rapidly into ulcers. So it's seldom to find a vesicle appear. You can examine a patient as an ulcer, but you cannot find the vesicle or pulla. Okay, ulcers are easily traumatized from teeth, food, and they become secondarily infected by the oral flora. So regarding the secondary ulcers, we will have a disease that causing vesicle or pulla. This can be easily traumatized by teeth or by food, for example, and break easily and rapidly to ulcers. Okay, and it may become secondarily infected by oral flora, become infected ulcer. These factors may cause lesions that have a characteristic appearance on skin to have non-specific appearance on the oral mucosa. So, first of all, if there is a disease having oral manifestation and skin manifestations, the oral manifestation will appear first. Okay, and if there is an ulcer here and here, the ulcer in the oral cavity will appear first. Okay, secondary ulcers. Okay, regarding secondary ulcers, we can going deep in this topic. Vesicular bullous lesion that preceded the ulcer may be the vesicle or pulla. The vesicle or pulla came from where? Either from intraepithelial vesicle or subepithelial vesicle. So the destruction within the epithelium could be occur within the layers or behind the epithelium, subepithelially. Why these vesicle or pulla ruptures? We said it before, because of mechanical trauma, friction, or bite, or by foods. What are the intraepithelial vesicles? The intraepithelial vesicles then classified into two types. They are acantholytic lesions, and these acantholytic lesions characterized by breakdown of the connection between the cells. So the lesions produced by breakdown of a specialized intracellular attachment known as desmosomes that connecting cells together and make them working in a harmony. That's the normal physiological process. Okay, so breaking down of this intracellular connection or attachment or desmosomes leading to rupture of these cells and leading to destruction of the parts of the epithelium regarding these cells, leading to pulla or vesicle formation. We have another type of the intraepithelial vesicle, which is non-acantholytic lesion. Non-acantholytic lesions related to the viral infections. The virus, to make infection, the virus will enter inside the cell, okay, and make replication of themselves, then producing many virants, and those virants will attack many other cells, and after finishing their replication, this cell will rupture, okay, apoptosis will occur. So the lesion produced by death or rupture of group of cells. Subepithelial vesicles, there is a destruction occurred beyond the epithelium or regarding the connection between the epithelium and connective tissue. So what will happen? Will separation of the epithelium from the connective tissue. Regarding these chronic diseases as mucous membrane pemphigoid, bullous pemphigoid, and others. So, at a quick recap, vesiculopullous lesions related to secondary ulcer could be superficial, intraepithelial, either acantholytic or non-acantholytic, or will be deep as a subepithelial. Okay, regarding the mode of onset and clinical presentation, oral ulcer can be detected as a single ulcer or multiple ulcers or recurrent behavior ulcers. Single ulcers such as traumatic ulcer, TB, syphilitic, histoplasmosis, blastomycosis, and mucormycosis. Okay, this will help in the diagnosis of this ulcer and to detect the cause easily. Either neoplastic ulcers. Okay, so this chart will help to diagnose the single episodes of ulcers, either related to infection, drugs, or iatrogenic, either by radiation or chemotherapy, or traumatic. Okay, multiple ulcers could be acute or chronic, and those of acute, they are most of them are viral and erythema multiforme and contact allergic stomatitis, and ulcers secondary to cancer, chemotherapy or radiotherapy could be appear as an acute multiple ulcers after the treatment starting. And the ANAG also, it's an acute condition. Okay, chronic multiple ulcers related to the chronic diseases, as we said before, subepithelial bullous dermatosis and herpes simplex virus in the immunocompromised patients will be chronic. Okay, recurring oral ulcers, they are recurrent of this stomatitis, Behçet syndrome, recurrent herpes simplex virus infection, and this will be discussed later. And this is a chart that can help you to diagnose. Regarding the anatomy of the ulcer that must be understood by you all, we have margin, edge, floor, and basis. Margin is the junction between the normal epithelium, okay, and the edge of the ulcer. Okay, and the edge is the area between the margin and the floor. The floor is the exposed surface of the ulcer, the exposed, that the area I can see it by my eye as grayish yellowish. Okay, the base you cannot see, but you can feel. It's where the ulcer rests on. The margins could be a healing margin, inflamed margin, and fibrous margin. The base could be indurated or not indurated. Regarding the edge, it can be undermined, punched, sloping, everted, and rolled. The floor can be covered or uncovered. Okay, the types of the margins. Healing margin will be white or blue and red. The white will be outline, could be white, okay, and the blue in the central area and the red inner. That the characteristic of the healing margins. Inflamed margin must be red, can be irregular with inflammatory surrounding skin, and the fibrous margin, it will be of course wide and thick area. Okay, regarding the edge of the ulcer, the edge is the area between the margin and floor, okay, can be undermined edge, just like this. Okay, this is occur in the tuberculosis ulcers. It can be punched out margin. Okay, you can see it. Trophic ulcer or diabetes ulcer. Sloping edge can be an healing ulcer, and everted margin, okay, in the squamous cell carcinoma, and the rolled out margin is in the basal cell carcinoma.